Shavua Tov. The rabbis of Bergen County, of all the denominations, are thrilled to be partnering on this event with the Jewish Federation of Northern New Jersey. Federation is the safety net for our Jewish community. Through their fundraising efforts, their resources, and access, they are always assessing the needs of the community and distributing funds and resources to address unmet needs. The RCBC and NJBR work very closely with Federation and value this relationship immensely. The fact that we have all come together to present tonight's program points to the fundamental and central Jewish value that tonight's topic centers on: the preservation of life and the role that community can play in that. I appreciate the opportunity tonight to publicly thank Dr. Jarrett. On March 11th, 2020, Dr. Jarrett presented to the RCBC about what he expected to occur with the emerging pandemic and what he recommended that we do. His voice played a major role in guiding us and truly saved lives in our community. Secondly, Dr. Jarrett did something extraordinary. He spoke with me every single week since then in order to update me on what is currently happening and what he recommends that our community do. These updates were invaluable and helped me and my colleagues guide our communities based on expert scientific knowledge. I believe that Dr. Jarrett and Holy Name Hospital did this because they see that their role is not only to provide an excellent hospital, but to do everything possible to improve the health of the community. We are indebted to you for your vision and for sharing this core value. Lastly, I want to thank you for sharing so much of your personal experiences in your new book that offers so much insight and inspiration based on the experiences of our healthcare workers. I am sure that tonight we will get a meaningful taste of that, and I look forward to hearing your talk. I would now like to ask Rabbi Manasov, the Vice President of the North Jersey Board of Rabbis, to introduce Dr. Jarrett.
Thank you. Just to reiterate, it is so good to all be together tonight to hear from Dr. Jarrett and engage in this important topic. A few weeks ago, when the planning began for this evening, it was an obvious alignment of why tonight was so important for our community and why having a night with Dr. Jarrett made sense in the context of the entire Jewish community of our area, why RCBC, the North Jersey Board of Rabbis, and Northern Jersey Federation was the appropriate group for such a program. I want to take a minute to think about how incredible that is, that here we are at this night sponsored by the RCBC, NJBR, and Federation. Tonight's conversation is not just timely and relevant as we continue through the pandemic. Tonight is also relevant because of our Jewish perspective on life, healing, and the great power and responsibility of doctors. As Jews, we know that the necessity of saving a life overrides every other mitzvah. If there is a possibility to save a life, that is our focus, and that supersedes just about everything else. But it is more than that. Time and again, the Torah and our ancient texts and sages call on us to see each and every life as sacred and to appreciate the sacred work of our medical professionals as they answer not just their medical oath, but the words of our sacred tradition. One brief teaching to bring to light the sacred work that Dr. Jarrett and really all of those who have been on the front lines have been doing. Doctors are truly God's partner, helping to fulfill the vision that God has set forth for us. In this world, doctors are truly God's partners, helping to fulfill the vision that God has set forth for us in this world. And our sages have understood that in analyzing and framing our sacred Torah. 2 verses from the Torah to frame our evening and shed an ounce of light on this partnership. The Torah demands us to not stand idly by the blood of our neighbors, but more to the point, to love our neighbors as ourselves. As interpreted and parsed by our sages, for a physician, this is a call to action, that when a doctor sees the possibility of healing or providing relief, that is what they are to do. And that is the guiding principle within the framework of a love for humanity. In early March of last year, Dr. Jarrett and his colleagues saw the possibilities that loomed ahead, and that is what he did. He got to work to ensure that he did not stand idly by the blood of his neighbors. He worked to save each and every precious life and to guide the hospital and our community into safety, to save as many precious souls as possible, despite the uncertainty and the unknowns that weighed on him and all of his staff. The Torah gives us the words, and we give meaning to life to those words. And this is what happened over the past 11 months, watching the incredible work that truly demonstrated the sanctity of life, a value that we Jews hold so dear. And still deep into the pandemic, that is exactly what Dr. Jarrett continues to do, to give life and meaning to our sacred text and tradition through his holy work, his sacred partnership with our community and with God. And we are beyond blessed for all that he has done and for being able to present this evening. We are so happy that Dr. Jarrett has agreed to answer your questions following his presentation. Please share any questions you have in the Q&A function at the bottom of your screen. And when Dr. Jarrett's presentation is over, Dr. Pavel will share the questions with him. Thank you so much, Dr. Jarrett. I turn the evening over to you.
Thank you, Rabbi. So I just wanted to start by thanking Rabbi Shiowitz and Rabbi Manasab and really all the rabbis I've been speaking to on a regular basis. This is absolutely a partnership. As we know, health is not just what happens in the hospital or in your doctor's office. It's what happens in the community. And this pandemic, this virus, COVID-19, is a perfect example of that. The actions that were taken by the Jewish community in Bergen County really was spectacular in terms of preventing the pandemic from being even worse, and really did save lives. And if I played a small part in that conversation, I'm great with that. But I also have to tell you, it takes a community to hear what was being said when many people were skeptical, and to take the kind of action that the Jewish community in Bergen County took to really have a major impact to save lives and to keep people as healthy as possible. So when I get asked today what's going on with COVID-19 and the pandemic, I start that conversation with where things are in the hospital today, how that differed from where we were back in March and April, and also what we're seeing in our outpatient setting. There is no doubt that this COVID-19 pandemic continues to have significant impact on our population in northern New Jersey, but it is very different now, thank goodness, from where we were back in March and April. And the reason that is still a little bit unknown, but probably relates to the fact that we were impacted so severely in March and April that there were enough people who developed immunity, and to be frank, enough people who actually succumbed from the disease, that the impact that the disease is having now, although still very significant, is nothing like we saw back in March and April. So back in March and April, at our peak, we had over 250 patients in the hospital with COVID. And at our peak, we had over 45 patients in intensive care units on ventilators. In the second wave, our peak has been in the low 70s. We've had as high as 72 patients in the hospital and as high as 15 patients on ventilators. So a significant decrease in volume, thank goodness. And I really believe that is related to how hard we were impacted back in March and April, and also with the good work that the entire community is doing in terms of the things we know we need to do to keep ourselves as safe as possible. And I don't want to sound like a broken record, but that has to do with masks and social distancing and not gathering and washing hands. And between those safety measures and the fact that we were hit so hard back in March and April, we're just not seeing the same volume of patients in the hospital. And that's not just at Holy Name, that is at the other hospitals in northern New Jersey. Myself and our chief nursing officer, as well as the chief medical officer and chief nursing officers of Hackensack and Valley and Newbridge and Atlantic Health, we get together at least 3 times a week. And the volumes that we are seeing are not dissimilar to the volumes that are being seen at the other hospitals. At Holy Name, we've been very, very fortunate. We did an awful lot of scrambling back in March and April in terms of creating new beds and in terms of gathering PPE and putting the kind of processes in place that could keep our patients and our staff as safe as possible. And we were smart enough to know that after the first wave, there was likely going to be an additional wave, and that's what we're in the middle of now. But because of the things that we built back in March and April, we're in a much better place in terms of day-to-day operations at the hospital. So we built close to 100 additional beds that can be used for critical care beds during that first wave. And they were empty for quite a time, but unfortunately, several months ago, they started being used again. And because of those additional beds that we were able to build, we've been able to maintain our entire COVID population and our staff that is dedicated to taking care of COVID patients and keep them separate from the rest of the patient population. And so we currently have 3 units that serve only COVID patients. So when I say the volumes are not as dramatic as they were back in March and April, this is still a second wave, and it is still impacting an awful lot of people, so much that we have 3 inpatient units that are dedicated strictly to COVID, and about half of our emergency department is dedicated to COVID. And unfortunately, this disease continues to take lives. So the vast majority of people who get COVID do just fine. And that's the good news. The bad news, and I don't want to sound again like a broken record, but the bad news, and the reason we all need to be so careful about social distancing and wearing masks, relates to the fact that for a very small population of patients, this disease is very serious. And the vast majority of patients who become critically ill and who end up on ventilators, unfortunately, do die. And so the mortality rate for this disease is not as high as we thought initially, but it is still somewhere around the 1% range. And what that means when you have a disease that is so infectious and it infects so many people, then you're going to see significant mortality. And that is why we are climbing close to 400,000 deaths in the country. And that is why we need to be so careful about this disease. And that's where we are today. From an outpatient perspective, we continue to test well over 300 patients a day. On the outpatient side, our positivity rate ranges from the 15 to 20% range. So there's an awful lot of COVID out in the community. We don't know how that compares back to March and April because we did not have the ability to test people back then. But we know now that 15 to 20% of the people that we test are positive, which means there's an awful lot of disease out in the community. We do have some good news in terms of treatments. The most optimistic treatment that we have are the monoclonal antibodies. That is the medication that President Trump was given when he was sick. That is the medicine that I'm proud to say Holy Name gave the first patient in the United States, actually in the world, was the first patient treated with monoclonal antibodies. That was at Holy Name. We're very proud of that. What we do know is that patients who are treated with monoclonal antibodies early in their course of disease, before they are sick enough to get put into the hospital, actually have a significant clinical response. And I'm very proud that we're treating between 15 and 25 patients a day with monoclonal antibodies at Holy Name. Other treatments in the hospital, probably not as effective as those monoclonal antibodies. So you want to do everything you can to stay out of the hospital and get those antibodies, but we are absolutely using remdesivir, the medication that you probably have heard of, as well as steroid medications, which also have shown to have some benefit. But the real breakthrough is likely these monoclonal antibodies. And the good news is they are much more available. And if you were to come down with COVID-19, I strongly recommend you speak to your primary care doctor to find out if you're a candidate for those monoclonal antibodies. I wanted to talk a little bit about my book. I'm not an author. I had not written a book before, and I was at a socially distant event with a friend, and that is my co-author by the name of Paul Rosengren. And Paul and I were talking about COVID-19, which was back then pretty much the only thing people were talking about. And Paul, who is a bit of a writer, said to me, "Wow, you have some amazing stories. Have you ever thought about putting them down and possibly writing a book?" And I was intrigued by the idea. Paul and I got together several hours every evening for about a month. And at the end of that month, realized that we probably had the makings of a book that we thought was worth telling. I was very proud of the work that people did at Holy Name, and I wanted to share that. And so we, for 6 months, worked on that. And after 6 months, which in the world of book writing, I'm told is a relatively short period of time, we were fortunate enough that we actually were able to get a book published that I'm actually quite proud of. I hope many of you get a chance to take a look and read through it. I think it does do a good job letting people know what Holy Name went through and the kind of work that we did at Holy Name. The book, unfortunately, is already a little bit outdated, right? Because we're talking about a pandemic where things are changing on an everyday basis. So as we say early on in the book, there are things in the book that have changed and actually may already be out of date. But I think the book still, most importantly, gives a feel for what it was like to be at Holy Name and to be a caregiver and to try to care for patients really during this once in a lifetime pandemic that we all were living. I'm going to do a couple of readings from the book. I'd like to initially read about some of the work that our team did at Holy Name that I was particularly proud of. You know, when you think of healthcare, you think of doctors and nurses and technicians, but the thing that I probably was, well, I don't want to say most proud of, but very proud of, was the work that our facilities people did. We realized that the hospital, and really no hospital, was prepared for this type of pandemic. And we quickly got together and realized that we needed to do some things differently. And we sat down very frequently and developed some new technology and really did some things that were quite remarkable. And I'm going to read a small section of the book that discusses some of that innovation and some of that technology that we developed for the pandemic. Steve Mosser, our head of facilities, innovations were not limited to construction of the COVID-19 wards. He also designed a personal negative pressure pod, which we called the isopod. Isopods were boxes made of plexiglass with a top and sides, but no bottom. They went from just above a patient's head to just above the knee. By the patient's head, each isopod had a duct that sucked air from inside the container through a filter, creating a mini negative pressure space that stopped air from escaping into the outside room. Each pod also had holes on the side of the boxes, big enough that nurses could reach through to provide necessary care to the patient. We initially intended to isolate all suspected COVID-19 patients in single rooms, but that just wasn't feasible with the number of patients we admitted. Isopods allowed us to place 2 patients in a single negative pressure room while we were awaiting COVID-19 test results, which at the time took 5 to 7 days to receive. The ability to put more than 1 patient in the same room without risking cross-infection, thanks to the isopods, was a game changer. I'm not sure if Steve was a Get Smart fan, but if he was, the isopods might have been inspired by the cone of silence. But unlike the technology in the 1960s TV show, these pods actually worked. As we do with much of our new technology, we tested the isopods in our simulation center prior to using them with real patients. The simulation center allows us to replicate real-life situations by practicing on lifelike mannequins. They speak, their eyes react to light, they can be hooked up to IVs, and their skin can change color. We regularly use simulations to practice complex robotic surgery or patient-caregiver interactions. Simulations help build team cohesion and improve communication, which is an increasingly important skill as the practice of medicine becomes more complex. For example, simulations have undoubtedly helped how our stroke and heart attack teams care for patients by improving response times in managing these medical conditions. When Steve built the first isopod, I was skeptical that it would work in real life, so I was eager to test it in the simulation center. When I walked in, a large group of people were gathered around a mannequin inside an isopod. I had planned to watch quietly, but my skepticism got the better of me when I saw the holes in the side of the pods. "Steve," I blurted out, "this isn't airtight. It's not even close." "Don't worry," Steve said. "The pod doesn't have to be airtight. It just has to draw a steady flow of air into the pod and out through the duct." I raised my eyebrow, still unconvinced, and Steve laughed. "You're a doctor, not an engineer, damn it." He knew a Star Trek reference would win me over. "Just stay in your lane." With that, he pulled out a bottle and sprayed a fine white powder into one of the holes on the side of the pod. As intended, the powder was quickly pulled out of the pod, then into the duct and out of the room through a filter, simulating the path of an aerosolized virus emitted from a patient. The same thing happened when he sprayed the powder into a larger opening over the mannequin's legs. This was much further from the duct, but Steve knew that the negative pressure would easily do the job. He looked pleased. He had done it again. I reminded myself to trust my team, and as Steve so eloquently put it, to stay in my lane. So that's a brief reading about how we use negative pressure at Holy Name. The good news is that we are no longer using the isopods. Thank goodness, and hopefully we won't need to use them. The isopods allowed us to treat 2 patients in one room before we could get test results back. And the good news is we now can get test results back very quickly. When we are admitting a patient to the hospital, we can get a COVID test result back now within an hour or 2, and that has dramatically changed the way we take care of patients in the hospital. There are still challenges though, because the test for COVID-19 is not a perfect test, as no medical test is, unfortunately. And we discussed that in the book quite a bit. But we do have situations, not infrequently, where we have patients who have negative tests, but we still think that they have COVID. And although we're not using the isopods, we still are challenged with that population of patients who have negative tests, despite the fact that we are still convinced that they have COVID. Fortunately, we're able to keep those patients isolated because we are not seeing the same volume of patients that we saw back during the first wave. I wanted to talk a little bit about vaccines. I'm sure that is on everyone's mind. The vaccine is really a miracle. For our scientists to have developed a vaccine in the time period that they developed is really quite amazing. The good news is I'm not hearing a lot of reluctance about people willingness to take the vaccine. Unfortunately, the bad news is there's just not enough vaccine available yet. We should talk a little bit about the medicine and the science of the vaccine. The 2 vaccines that are available are new technologies. They use synthetic mRNA. So they use mRNA, which is a substance that occurs naturally in our body to make proteins. The scientists have been able to synthesize that mRNA in the laboratory. So it doesn't use any type of animals or live cells for the actual making of the mRNA. The mRNA is then injected into us. The mRNA goes into our cell. It then triggers the body to produce a protein. The protein, which is similar to the surface protein on the surface of the COVID-19 virus, then triggers the body to have an immune response, and that then protects you from COVID-19. The two vaccines that are available today require 2 injections, one of the vaccines at 21 days, that's the Pfizer vaccine. The other vaccine requires a second injection at 28 days, that's the Moderna vaccine. We are, thank goodness, seeing very minimal reactions to the vaccine. We certainly are seeing patients who are developing low-grade fever. We're seeing patients who develop body aches. We're seeing some patients who have fatigue. We've even had a handful of patients get the vaccine who've had to miss a day of work after the second vaccine because of the severity of the reaction. But thank goodness we're not seeing any more significant reactions than that. At Holy Name, we've vaccinated well over 4,000 people at this point, which is unfortunate that it's a relatively small number. But as of today, we are actually out of vaccine. We have vaccinated our entire medical staff and our entire employee staff. And then late last week or late this week, we began vaccinating the public based on the governor's guidance in terms of who should be vaccinated. The vaccine availability that we had, unfortunately, went very, very quick. And we vaccinated about 600 people on Friday and on Thursday and over 1,000 people on Friday. We are cautiously optimistic that we are going to have more vaccine available early next week. The Holy Name website is a place you can go, and I'd keep an eye on to see when vaccine becomes available, because you will be able to sign on that website. And we are vaccinating the community when we get vaccine available up at the Rhoda Center in Teaneck. On Thursday and Friday, we had 12 to 14 people vaccinating continuously, really until we ran out of vaccine. I know people are anxious to get the vaccine, and clearly the sooner you get the vaccine, the better. But the reality is there's just not enough vaccine available. But I do expect, and I am cautiously optimistic, that over the next several months, there will be enough vaccine available for everyone to get that vaccine. So what do we do in the meantime? Well, in the meantime, we need to follow the rules of social distancing and wearing masks and hand washing. That's true whether or not you receive the vaccine. We know the vaccine after you receive the second dose is about 90 or 95% effective, which for a vaccine is really quite incredible. What we don't know for sure, and what is very likely, is that even after you get the vaccine, you still may come down with a subclinical form of COVID-19, a form of COVID-19 that does not get you sick, but has the potential to infect the people around you. So really, until we as a community and as a nation have vaccinated enough people that we can believe we've reached herd immunity, and that's in the 75 to 85% range, we're going to need to continue following the social distancing rules that we've discussed earlier. That's extremely important. Wearing masks is extremely important. And in fact, I'm going to talk a little bit about wearing masks now from the book. I'm going to read a segment in the book that I feel passionate about in terms of how we as a nation dealt with masks and how we as a nation need to admit that we didn't get it right as it relates to masks. And I myself did not get it right as it relates to masks. And here's a section on the book about mask wearing. Prior to COVID-19, medical personnel typically wore masks to protect patients who were vulnerable, not themselves. For example, nurses and doctors wear masks in the operating room when someone is undergoing surgery, or in the rooms of patients who have compromised immune systems. When COVID-19 first arrived in the US, the general public was told to not wear masks. Masks were scarce, needed by hospital workers, and we thought they were unlikely to protect the wearer. Early on, that's what I told people. Wearing a mask was an unnecessary precaution. But then we gained a better understanding of this virus. It is spread by asymptomatic people, and therefore wearing a mask is less about protecting you and more about protecting others, like grocery store workers and the gas station attendant, because you might have the disease and not know it. Our essential workers are truly essential. They are not able to stay home because we need them to help run society. So we need to protect them as much as possible. When health organizations and medical professionals began to recommend that every person wear a mask outside the home, not everyone took this recommendation seriously. My cynical side thinks that more people may have worn masks if they had been told it was to protect themselves rather than to protect others. Eventually, the science did prove that wearing a mask also provides a level of protection for the wearer in addition to protecting others. Consistent mask wearing outside the house is now the current recommendation, though some still refuse to follow this guideline. My favorite example of how mask works is a simple one. Imagine a place where no one wears pants. If another person pees on you, you get wet. Now, if you put pants on and someone pees on you, you still get wet, but less so. But if the other person wears pants and pees, you will be fine. Maybe a little graphic, but it makes the point. Wearing a mask provides you some protection, but more importantly, wearing a mask helps prevent you from infecting others. It amazes me that wearing or not wearing a mask has become political, and that many people resist wearing one because they feel it infringes on their freedom. Once COVID-19 was prevalent in our community, it simply made sense to put on a mask. In retrospect, we all should have been more open to wearing masks from the very beginning. In the New York metropolitan area, mask wearing is likely the single most impactful thing we have done to decrease new infections. If we had embraced wearing masks sooner as a nation, and if there was still not resistance to this simple act, we could have significantly decreased the COVID-19 infection rates and mortality rates. We can't deny that the medical community gave poor advice regarding masks at the start of the pandemic. There's no shame in admitting we made a mistake, especially if we learn from that mistake and then apply what we learned, as we have done in this situation. What is shameful, however, is the deliberate and intentional spread of misinformation, which can take on a life of its own and prove disastrous in a pandemic. Wearing a mask does not impede oxygen flow to the brain, nor does it increase the likelihood of spreading the disease. Both of these claims gained traction early in the pandemic and are still parroted by anti-maskers today. Some anti-maskers also claim that stores and other establishments that require masks violate a legal right. Also untrue. Requirement that shoppers wear a mask are no more an infringement on freedom than are requirements that shoppers wear a shirt and shoes. I like to compare wearing a mask with smoking. Until relatively recently, smoking was unregulated. Non-smokers may not have been happy to breathe in secondhand smoke in restaurants or planes, but it was thought to be nothing more than a nuisance. Once clear scientific evidence showed that breathing in secondhand smoke was harmful, the laws changed. It is unfair and, frankly, wrong to allow innocent bystanders to be harmed by the actions of others. That is why you cannot smoke in an indoor public space, and that is why you should wear a mask during a pandemic. So even that may seem a little bit outdated, that part of the book. I like to think that people are doing a little bit better job wearing a mask. I know that is certainly the case in the Northeast. It still may be a bit of a struggle, unfortunately, in the rest of the country. But I would say that the same way that I make the point that you wear a mask, not just for yourself, but to protect others. I'll get back to vaccines for a second. You get vaccinated to protect yourself, you do. But as importantly, you get vaccinated to protect other people. And if there is a reluctance to take this vaccine because of concerns for safety, people should be reassured that this vaccine is showing itself to be very safe, that when you take it, you are not just protecting yourself, but you're protecting others. And I strongly recommend that as soon as vaccines are available for everyone who's on this call and really everyone in the country, that people take vaccines. It will allow us, it is the one thing that will allow us to get back to some level of normalcy. And I'm optimistic that that will happen later this year, maybe even as early as the middle of the summer, but certainly by the fall. So that ends my formal presentation. I hope I haven't gone on too long. I know Dr. Pavel is going to take some questions. I'd be more than glad to answer any questions, discuss the book or what's going on now with the virus or testing or the vaccine or really any questions whatsoever. So Dr. Pavel, I'll pass it off to you.
Great. Thank you, Dr. Jarrett, and thank you for such a great comprehensive talk. We have a lot of questions, so I'm going to get right to it. There are some questions on the chat, and if those people who place their questions on chat can place them in the Q&A section, which is on the bottom of your Zoom screen, it's going to be easier for us to get your questions and ask them. First questions, Dr. Jarrett. We have a lot of different questions about the monoclonal antibodies on a lot of different levels. The criteria for getting a monoclonal antibody, how to take a monoclonal antibody, how is it given, what is the course of treatment, who's able to get it. So as detailed as you can give, people have plenty of questions, probably about 10 to 12 questions about monoclonal antibodies.
Sure. So here's the good news. The good news is that the CDC has expanded who qualifies for the monoclonal antibodies. The other piece of good news is monoclonal antibody availability is pretty good. We have close to 1,000 doses of monoclonal antibodies at Holy Name, and other hospitals in the area have doses as well. So the criteria has been changing, but I will tell you what the current criteria are. The current criteria is having a known COVID positive test and having some level of comorbidity. So early on, you needed to have symptoms of COVID-19. You no longer do. You do need to have some level of comorbidity. That comorbidity could be age by itself. So being 65 or older and having COVID, a positive test qualifies you for the antibody. And really any other level of comorbidity. So obesity, diabetes, emphysema, hypertension, heart disease, cancer, really any chronic medical condition and a COVID positive test now qualifies you for the antibody. I can tell you how you access the antibody at Holy Name Medical Center. My best advice for you is that you use your primary care physician for all your care. But at Holy Name Medical Center, you could access the antibody by speaking to your primary care doctor who could register you and get you enrolled for the antibody. If you don't have a primary care doctor and are concerned, you can go to our website where there's information about how to get access to the monoclonal antibody. The good news is receiving the monoclonal antibody is not an emergency. So if you're sick today or if you have a positive antibody today, we don't rush people in for the monoclonal antibody like we would do for an emergency. So we typically have people that are known positive and schedule them for the monoclonal antibody within 24 hours. You certainly don't want to wait significantly more than that. At Holy Name, we've set up a separate infusion center for the monoclonal antibody. So you come into the hospital via a dedicated entrance just for COVID patients who are coming in for monoclonal antibodies. You go into an area that we've dedicated for infusion of the monoclonal antibody. The infusion itself takes a little less than an hour. The whole process takes a little bit more than 2 hours in terms of registering, getting the antibodies, and then allowing us to watch you afterwards. We are not seeing significant reactions from the monoclonal antibodies, thank goodness. We have unfortunately seen a handful of patients who, despite the monoclonal antibodies, have still ended up in the hospital. And unfortunately, the monoclonal antibody is not a magic bullet, but we do think that receiving the monoclonal antibody significantly reduces the risk of you going on and having more severe disease.
Thank you. Thank you, Dr. Jarrett. One last question regarding the monoclonal antibodies that just popped up is the cost, and that's, I guess, a determining factor. Is this covered by insurance?
It is. Yeah. And so the good news is with the first CARES Act, really all treatment for COVID-19 with 95% of insurances people have, or even for the uninsured, is fully covered, and the monoclonal antibody is considered an acceptable treatment now. There is one other thing I'd like to bring up about the monoclonal antibody. The final scientific verdict is still out a bit on the monoclonal antibodies. We strongly believe they're effective, but we're still figuring this out on the go a little bit, which can be a little concerning. I understand that. But there is a study that we're doing at Holy Name Medical Center in terms of trying to sort out the monoclonal antibodies. So if you come to the hospital with a positive COVID test and the other risk factors that I mentioned before, you will get monoclonal antibodies. You will not be part of a study. But if you are exposed to someone in your house who has COVID-19 and you do not have COVID-19 and are interested in participating in a research study, we are involved in a study that is looking at whether or not receiving the monoclonal antibodies with a household exposure, despite being negative, reduces the risk of getting COVID-19 or decreases the severity of getting COVID-19 if you do come down with it. So besides the other things that I mentioned, if your loved one or whoever you're living with develops COVID-19 and you're interested in participating in a study and possibly getting the monoclonal antibody through that study, you can access that information on our website. In that study, there is a 1/3 chance you will get a placebo. That's the way studies work. But 2 out of 3 people who enroll in that study with a household exposure will get the monoclonal antibody.
Terrific, thank you. Dr. Jarrett, I'm going to put together a lot of different questions. There's a myriad of questions about the different stages of treatment of COVID and what's being done at Holy Name. I know on page 127 of your book, you go through a bunch of different stages of the treatments and the different paradigms. I could say as a doctor who's also working, I've never seen such evolution of care so quickly in the hospital setting for a disease. So it's really been incredible from March to now, the different treatments. So I'm going to leave it to you. There's many different questions about medications, but I think on page 127 of your book, you go through the different steps, treatment at the different stages of COVID.
Yeah, so that part of the book I think is particularly worth reading if you don't want to read the whole book. It goes through what we knew at the time that I wrote the book and hasn't changed a whole lot in terms of what we know today. And so primarily, it centers around the fact that the vast majority of people with COVID do just fine. And so I use myself as an example. I have not gotten COVID, but if I did, I would try very conservative measures. I would treat it very much like a flu-like illness, and I would stay home and I would take Tylenol or ibuprofen, and I would stay away from people and I would drink lots of fluid. The one caveat is I would actually try to get monoclonal antibodies, although I would not qualify. I do not believe. I do not have any chronic conditions. I might enroll in the study because the study also allows people without chronic conditions to potentially enroll in the study and get the monoclonal antibodies. But I would stay home. I would not take hydrochloroquine. right? I would not take Zithromax. There are some people who are pushing those medications still, and I think the evidence is pretty clear. I am not someone who is a great believer in vitamins and over-the-counter supplements, but there's some evidence that vitamin C and zinc may help. I probably would not take those things because I'm not a big believer, but I would not give a patient a hard time if they chose to do those things because I know there's no downside. And I would stay in touch with my primary care provider, and that's what I would do. And if I was fortunate enough to get the monoclonal antibodies, that and staying in touch with my primary care provider would be all that I would do. If I started feeling short of breath, to me, that is the significant symptom that potentially requires hospitalization. I would go to the hospital and I would want my doctors to start me on 2 medications. The medication that I am most confident about that is beneficial for patients who are beginning to get short of breath is steroids. I think that early steroids in people who have significant inflammation, which is what this disease does clearly have an impact on morbidity and mortality of this disease. I also would take remdesivir, although there is now more and more evidence that the remdesivir may not be as helpful as we initially thought, but it's the one antiviral that there is any evidence that it is beneficial. And so I would take the remdesivir, but unfortunately, we're seeing an awful lot of people who get remdesivir who still progress quite a bit. So I would want to be on steroids and remdesivir. And I'd also ask my colleagues at Holy Name if there were any other potential studies I might be eligible for. At Holy Name, we have about 9 other studies that people could enroll in with other antiviral medications or other medications that help to help the immune system. After that, I would hope that I would get significantly better. I would tell my doctors they should do whatever they could possibly do to try to keep me off a ventilator. I don't say that easily because a ventilator can very much be a life-saving thing that patients need. But what we do know is that with this disease, if you end up on a ventilator, that it is very, very challenging to come off. And it's a difficult conversation to have, but unfortunately, the vast majority of our patients who've gone on ventilators have not made it. So I would tell my doctors, do everything you can to keep me off a ventilator, even knowing that that may increase some other things from happening, because being off a ventilator, if you need it, is a potential problem. And then I would say to my wife, who I've had this conversation with many times, take the doctor's advice. If they tell you that it's not looking good and the chance of me getting off that ventilator is close to 0, I would actually be taken off the ventilator and be allowed to die with some dignity, because unfortunately, we are seeing patients on ventilators for 4, 6, 8 weeks, and it is not a good experience for patients. And it's a hard thing to talk about, but we do know that the vast majority of those patients who are on ventilators for any length of time just do not survive. And so I would very much not want to die in a ventilator. And I would very much, if possible, like to have my family around me, although in the time of COVID, that's very difficult, but I would very much like to have my family around me when my time did come. And so that's a very frank, honest discussion of the treatment for COVID. Please keep in mind that the vast majority of people who get COVID do not go down that path. The vast majority of people don't get hospitalized, but there are a small segment of people, and close to 400,000 in this country today, who have gone down that path that I just described, unfortunately.
Thank you very much for the frank discussion. Our next sort of classification of questions are all about vaccinations, and questions ranging from how long does it last? How long does your immunity last once you have it? Can you still transmit the virus once you have been vaccinated? When would it be safe to travel once vaccinated? Also, can you test positive for COVID after a vaccination, if you're able to answer that? Other questions include, when do you think there'd be time, there is a time when children will be offered a vaccine if noted to be safe? And others have asked about blood donations. Is that okay to give blood after you've been vaccinated? Do we know? If you know the answers, it's such an evolving field of medicine that whatever you can highlight here to the best of your knowledge.
Sure. So unfortunately, we don't know the answer to many of those questions, so I'll do my best. We know that in in the studies that the 2 vaccines that are available provide immunity after the second dose to 90 or 95%. That doesn't mean that every single person who takes the vaccine is protected. And if we vaccinate hundreds of millions of people, there still will be people, and there was one reported late last week of a person who got the vaccine, even got the second dose, and then developed COVID. That's going to happen because these vaccines are not perfect. And I think it's even likely that the effectiveness rate will go down even a bit below the 90 or 95% as we vaccinate more people. So everyone should get vaccinated, but that doesn't mean we can change the social distancing rules. 1, because it's not 100% effective, and 2, because it is still possible to transmit the virus, as we talked about earlier, even after you've been vaccinated. So I have not traveled on an airplane, and I do not recommend people travel on an airplane. And if you're going to travel on an airplane, I recommend you do it with an N95 mask and a face shield. And if you didn't travel before vaccination, I would say you should not travel after vaccination. Now, that's not always possible. Some people have no choice. I mean, I respect and understand that, but I don't think that the vaccination gives you the green light to really behave differently than you did prior to the vaccine. In terms of, are we going to need the vaccine a second time? We just don't know. I would say that the likelihood is that we will. We know that coronavirus in general do not give lifelong immunity. And so therefore, it's likely that this will be a vaccine that we will need to take every couple of years. The scientists are looking at the population of patients who got the initial dose of vaccine, and they're going to be able to tell us over the next year or two whether or not we're going to need more doses of vaccine. Remember, we get a flu shot every year. We've sort of worked that into our routine, and coronavirus may be the same. But we just don't know, and we're going to have to wait for the scientists to tell us what we need to do. In terms of children, I actually don't think there's a rush to vaccinate children, right? And I am not a big believer in early adoption of medications or treatment. But this COVID vaccine is different, right? It's a situation where we know the downside of taking COVID-19. Of not taking the COVID-19 vaccine. We know the downside of getting infected with COVID. And so therefore, we have to be an early adopter of a vaccine for anyone who is at any risk. The good news is that's really not children. Although this disease can affect a very, very small percentage of children severely, the vast, vast, vast majority of children who get COVID-19 do just fine. And so I think it's going to be quite a while until we're vaccinating children. I don't know when, but I bet it's a year or two at least. And I'm okay with that if we can do a good job vaccinating all adults. Dr. Pavel, did I cover? Was there anything I missed on the vaccine question?
Let me just check. I think you covered most of this. There are some questions about specifically immunocompromised patients or patients who are on, I'm a physiatrist, so we see patients who are rheumatological medications or immune suppressive medications. Are a lot of questions about are they candidates for the vaccine?
So they're absolutely a candidate for the vaccine. In fact, they should be amongst an early adopter of the vaccine. There's no reason to suspect they'll have a higher risk from taking the vaccine. They may have less of an immune response. Right. So if you're immunocompromised or taking a medication that suppresses your immune system, you may not get the same level of immune response. That's not a reason not to take it. In fact, it's even a reason to take it. You have a bit of a compromised immune system. Any additional immunity that you get is good. That's why it's extremely important that everyone take the vaccine, because again, when you take the vaccine, it's about you, but more importantly, it's about the people around you. And if you're immunocompromised, you want to make sure the people around you got that vaccine because they may get a better immune response than you do.
Great, thank you so much. We have a few questions about some of the newer variants that have been in the news of the COVID virus. The South Africa illnesses in England, newer studies that show that maybe there's a variant that's going to be more prevalent than the variant we're currently seeing, even in this country. A lot of questions speaking to that virus, whether it's more virulent than the virus we're seeing now. We know it's more contagious, but whatever knowledge you can impart about the new variants and how they're going to affect our community.
So viruses mutate and change every day, right? That's expected. When there's enough mutations or a mutation in a specific area of the RNA of the virus, that's when we see these potential new strains, and they have the potential to be scary. The good news, from an evolutionary perspective, viruses actually don't want to get more scary. They want to get less scary, right? They want to infect more people, but they want to kill less people, right? From a pure evolutionary perspective, if the virus kills off all its hosts, then the virus dies. So it is unusual for a virus to become more virulent. Not impossible, it can absolutely happen, but it's unusual. It's not unusual for it to become more infectious. It wants to be more infectious, but it doesn't want to be as virulent. It doesn't want to kill more people because then it's killing its host. So what we know now is that this virus is more infectious. It does not seem to be more virulent. It seems like the vaccine is going to be effective against this virus, this variant of the virus, but it is very possible that we will have to tweak the vaccine over time if the virus changes enough. It should not change anything that we're doing today. In fact, it should double down our efforts to do everything we're currently doing. It is not a reason to not take the vaccine. And if I had to make an educated guess, this strain has been with us for quite a while. It's probably in northern New Jersey. I know a couple of weeks ago it was the first case and everyone made a big deal out of it. But keep in mind that when we test you for this virus, we do not look at the specific RNA. We don't have that capability in day-to-day medicine. And so it's very possible that this new strain has been out for quite a while and we just weren't aware of it. And we are not seeing a worsening of how patients are being affected by the virus. So there's good reason to think that it's not more deadly, but likely just more contagious.
Thank you very much. Thank you. There have been a few different questions, and I put them all under the heading of both home monitoring via pulse ox and temperature, as well as home medicine, over-the-counter medicines. And if we're trying to have patients stay away from the hospital if needed, number one, do you recommend having a pulse oximeter at home to test your oxygen level? How accurate, people are asking, do you find that as opposed to having it done in the emergency department setting? And other home over-the-counter medications, ibuprofen, Tylenol, pseudoephedrine, things for congestion, and what you recommend, if you recommend anything, knowing that this is not a medical visit to everyone on this. Dr.
Correct.
Jarrett is going to give his thoughts, but this is, you have to speak to your own doctor regarding.
So I do think it's extremely important that you are communicating with a provider if you develop COVID-19 or anything. At Holy Name, in the beginning of the pandemic, we developed a telemedicine team. That telemedicine team has now taken care of over 10,000 patients who either had COVID or were suspected to have COVID-19. We continue to do that. For the vast majority of those patients, it's a conversation and it's reassurance, and we're here if you get worse, and we'll touch base with you in a couple days, but you call us. I would say of those 10,000 people we've treated, I would say well over 50% of them we're here if you need us. And if you develop a little fever, or if you have some body aches, and if you're tired, you can take some Tylenol, you can take some Advil, you can take some over-the-counter decongestants, as long as you don't have another medical condition that makes you avoid those medications, such as hypertension or coronary disease. And those types of medicines can be effective in terms of relieving symptoms. I'm not a huge fan of those medicines. I don't think people should take them unless they feel like they need them. I mean, if you have fever and you're uncomfortable from it, sure, take it. But if you have a little low-grade fever, just let it be. If you're a little achy and you can put up with it, just let it be. But if you're really achy and miserable, some Tylenol or Advil is fine. If you're a little congested and can put up with it, put up with it. If it's really, really bothering you, some over-the-counter decongestant is fine. In terms of home monitoring, I would say about 10% of the patients that we took care of had some sort of home monitoring that was prescribed by Holy Name. And typically it was a blood pressure cuff, a thermometer, and a pulse ox. Those pulse ox readings are pretty good. We never follow them blindly, right? Because doing that on yourself it just can't be as accurate as having a medical professional do it who knows what they're doing, but pretty accurate. And we have had situations in patients who had the beginnings of some shortness of breath, when the pulse oximeter let us know that they were getting sooner before the patient realized it. And so in those situations, and anyone who's feeling any level of shortness of breath, I do recommend having a pulse ox home and being able to communicate that information to your telemedicine provider, and then allowing us to use that information to determine whether or not you can come into the hospital. In the middle of the pandemic, we couldn't get pulse ox machines. They're now available. I do think that as a country, we should start thinking of a pulse ox the same way we think of a thermometer. And it's not a bad idea to have one at home, because it does give us a little bit more information and can help guide a decision about whether or not you need to come into the hospital.
Thank you very much. We're getting to the point of toward the end of our meeting, and one of the questions I wanted to ask was from Rabbi Shaiwitz, who had a personal question for you, but I think an interesting one. He asked me directly to ask you, in the beginning of this pandemic, and even during the pandemic, looking back on it, and the risks that you personally took by even going to work every day, and this is in the very beginnings of when no one knew whether touching the surface or touching your food or touching the mail could transmit this virus in a dose-dependent way that could really make you ill. Dr. Shaiwitz, Rabbi Shaiwitz, really wanted to know, looking back, do you either regret or have fear for some of the actions you took, even though you were a physician and you had to go to work, some of the instances or things that you had to do?
Yeah, so I think looking back, if anything, I was probably too cautious, which is good. I live in a one-bedroom apartment with my wife in Washington Heights, and she would meet me at the door, and I would strip and put all my clothes into a garbage bag, and I would jump right into the shower. And it's a one-bedroom apartment, so the couch became my typical sleeping place most nights for probably about 3-4 weeks in the very beginning of this, until we realized that was probably overkill. It absolutely changed our life and providers' life dramatically. But myself, as with all healthcare providers, I don't think we thought about it in that way. It's just what we do. There's a chapter in the book about the AIDS pandemic and comparing the AIDS pandemic, and I trained in Manhattan right in the midst of that. And in some ways, it was very similar. We were using needles. There was the concern of a possible needle stick. We knew more about AIDS, so we knew we could not pass it on without some very specific things happening, which was very different than this disease. But to be very frank, it was still very scary back in the late 80s and early 90s. We did not have the safety needles that we have today. It was very common for especially young doctors in training to get needle sticks. So that it reminded me of that experience. But it wasn't something, if you go into medicine, this is what you choose to do. And the vast, vast majority of our doctors and nurses just jumped right in. It was really, I never thought I'd have another experience in my career that was like the AIDS pandemic, right? Because that was 3 years training in Manhattan in the middle of the pandemic that changed my life, right? Things happened that I to this day look back on and recall, and was able to share some in the book. I think, unfortunately, we did it again, right? We had another pandemic, different in many ways, but similar in some. And we will look back on this 20, 30 years from now, and hopefully we won't have another one of these, but we need to be prepared that we could. And we'll look back on this the same way we look back on I look back on the AIDS pandemic from the late 80s and early 90s.
Thank you, Dr. Jarrett. I just wanted to say, as a physician who also worked during this and also trained during the time of HIV, this was, I think, much scarier, and it's admirable how well you guys did at Holy Name and all of our surrounding hospitals, Hackensack and Inglewood. But Holy Name, being in a suburban hospital, you think you're not going to be on the front lines of any really crazy disease process. And meanwhile, Holy Name, your emergency department and the whole hospital, and you as their chief medical officer, was really on the cutting edge of all of this. So I just wanted to thank you as a medical professional, and also on behalf of the clergy and the Federation, for being a leader in guiding them and the clergy and their congregations in really making the right decisions from March on about how to guide their own congregations in all of this. And I wanted to thank you and the Federation for having this tonight. It was really shown a great light on all the work that was done, all the things we still don't know, but on all the things we all need to do: mask wearing, social distancing, and getting your vaccine when you're able to. So for all the participants, thank you for spending an hour. The regret, I have to say, there is no kiddish after this. So you're going to have to go to your own kitchen like we all do now. And I wanted to say good night to everyone and thank you for the Federation for having this meeting.
Thank you, Dr.
Dr.
Ravel.
Jarrett, thank you again. And thank you, rabbis, for the great
Take care.
presentation.